Transforming healthcare through quality improvement is at the heart of Wisconsin Collaborative for Healthcare Quality, or I will refer to it as WCHQ. Under the banner of Powering Progress, WCHQ has improvement teams dedicated to making strides in areas like antimicrobial stewardship, behavioral health, immunizations, obesity, and much more. Today, we're excited to dive into the newly released WCHQ Health Disparities Improvement Toolkit. Our speakers will guide us through the toolkit, showcasing how pharmacy teams can leverage it to enhance access to care in their communities. First up, we have Christopher Barron, who serves on the WCHQ Board of Directors and is the Executive Director of Population Health and Clinical Services at Fort Healthcare, an independent hospital and health system in rural South Central Wisconsin. In his role, Chris leads both community level and clinical level population health efforts using data and analytics to drive outcomes, spark improvements, and rally stakeholders, all with one goal of improving the health and well-being of the community. Joining Chris is Megan Tim, a member of the WCHQ Disparities Work Group and the Regional Director of Community Health for SSM Health of Wisconsin. Megan leads efforts to conduct community health needs assessments, implement improvement plans, report community benefits, and build vital community partnerships. With a background that includes work in Western Alaska and now Wisconsin, Megan has dedicated her career to health equity, food as medicine, and reproductive justice. She's passionate about the power of community voices and believes in collective impact, ensuring that communities are part of the solution, not just consulted or educated. Rounding out our panel is Renee Sutke, a quality improvement specialist at WCHQ. Renee is a champion for increasing access to holistic healthcare for underserved populations. She works closely with health systems across Wisconsin to address and improve health disparities, behavioral health care, and health outcomes. With 16 years of experience in community mental health, Renee brings a wealth of knowledge and a deep commitment to her role. She holds a bachelor's degree in social work from Edgewood College and a master's degree in rehabilitation counseling from UW-Madison. Please join me in giving a warm welcome to our speakers for this morning's opening general session.
Good morning. Thank you for having us. I really want to thank my colleagues, Renee and Megan. I put them up to this so thanks for coming to the Dells, bringing your families, and welcome. We're here to talk about the WCHQ Health Disparities Improvement Toolkit, teach you a little bit about what health disparities are and tie it back to pharmacy. We have no relevant financial relationships. Our learning objectives after completion of the program, we want pharmacists and pharmacy technician learners to learn about what the Wisconsin Collaborative for Healthcare Quality is, learn about past health disparity projects, health disparity work that WCHQ has done. We'll showcase some of that and tie it back to pharmacy. Learn about opportunities to improve health quality and healthcare quality and reduce health disparities. And then also learn about current and future accountability related to health equity and reducing health disparities. There's a fair amount of that out there that'll tie back to the work we do. So before we start, we want to start with audience participation. So get out your apps if you have them. And we want to survey the group here. Where are you in your journey to reduce health disparities and advance health equity? Now, we have 4 options there. You may not fit one of the options exactly, but think of it as a spectrum from A, not just learning about this, to D, you're well versed in it. And we will see where everyone lands.
You don't have any fun music this
No.
morning, Chris.
No, need the Jeopardy music. You gotta refresh. There we go. All right, need my glasses. All right. Thank you. And that's about what we expect. There's a broad spectrum of where people are in this journey. Sometimes it's the first formal introduction to the concepts. You've heard the concepts. Your organization might have health disparity reduction goals, but you may not be an active participant in those goals. And then some are actively participating. That's great. And we even have some at the top end of the range that are actively participating, using quality improvement science, trying things, retrying things, measuring things. That's great. That's kind of where we're trying to get everyone. So thank you, Ryan. Oh, thank you. So with that, I'll hand it off to Renee. Tell us a little bit about WCHQ.
So we're good. WCHQ is a regional health improvement collaborative. So we work with health systems across the state of Wisconsin as a membership organization. Thank you, Ryan. I can hold it. All right. Thank you for bearing with me. So who's WCHQ? WCHQ is Megan and Chris and me. I work at WCHQ, right? But it's also sort of probably a lot of you in this room are part of WCHQ. Our membership organization isn't every health organization or health system in Wisconsin, but it's about 75%. And so we collect data from those 75% health systems across the state, and we publicly report that data. It's on our website on a host of quality measures, from blood pressure control to A1C testing, A1C control to depression screening and immunization. So a lot of pharmacy related topics around those quality measures. And then we take that data and we work in our improvement teams to bring meaning to the data and bring improvement opportunities and share those opportunities, what works, what hasn't worked, so we can help save everybody some time and work efficiently across that collaboration. So really our spirit is improving the healthcare for all of Wisconsinites and working with health systems to do that. So we invite you to think about the opportunities to connect with WCHQ.
So before we jump in too much, we wanted to make sure everyone was on the same page regarding some definitions that we're going to be talking about today. So everyone has heard health equity and health disparities and inequities, and sometimes those words are interchangeable, and other times we really do want to differentiate between the two. So many of us have health equity metrics that we are currently working on within our health systems from the Joint Commission or CMS. However, the noticeable distinguishable kind of definitions here. So an inequity is a disparity, but it's really rooted in systemic issues, right? So preventable perhaps, right? But really getting upstream on trying to fix those issues. And they are really related to systemic issues or societal issues, often linked back to our foundation of health as a human right. A health disparity is a difference in a health outcome. And that could be by race, zip code, gender, age, all of those things that we are typically looking at when we're looking at health disparities data. So hopefully that helps kind of set the stage for today.
I'll take that one step further from what Megan just described. A resource from CMS here describes that relationship between health equity and health disparities. Health equity is advanced when care providers identify health disparities. So you need data to do that. You need to identify where the disparities exist, and we'll show what we can do at the WCHQ level with that. Define specific and actionable goals for addressing any disparities identified. Prioritize populations and communities that are historically underserved. Establish and implement their organization's health equity strategy. Determine what tools and resources their organization needs to implement its strategy. Monitor and evaluate progress in addressing health disparities. So that's how CMS ties those two together, the relationship between health equity and health disparities. recognizing and addressing the issues that contribute to health disparities will help to achieve health equity. And then as we get into health disparities, we have a tighter definition at the WCHQ level. What does it mean exactly when we measure things, when we measure health measures, say breast cancer screening or diabetes care or hypertension control? What is it? What is the disparities we're looking for? Well, when we compare populations, we look at that percentage point difference between different populations. And the definitions that we've used through WCHQ and academic partners that have put this together is that 5 to 9.9 percentage point difference in population performance. Now you have a disparity. You get above 10 percentage points, now you have a significant disparity. So remember those things. That's how we kind of use data to identify what's there and then monitor the improvement of our efforts too. So with that, we'll give you a little background now on, Renee will tell us about some of the past WCHQ health disparity work that's been going on in Wisconsin.
So what we want to do is identify where disparities exist so we can improve those disparities. And we can do that at a couple of levels. At WCHQ, we do that at a statewide level. And in our improvement teams, we really work to look at areas of service and zip code level disparities, as well as the statewide disparities. So, two opportunities to think about improvement in the context of health equity across the state. These are two examples of our reporting. We teaser for a couple slides later, but we have really looked at rural and urban geography across the state of Wisconsin. We'll show you a map in a bit that really showcases how different the geography is around Wisconsin. And to help understand those disparities, we have a report on our website about that. And looking a little closer, I think that's the next slide. So I'll go to the next. That was the urban and urban rural.
Oops, sorry, I advanced it.
All good. But we put out a number of reports looking at specific quality measures and geography, race, ethnicity, and payer in the context of our disparities around the state. So really understanding where our impact can be and understanding that those interventions that we provide to improve specific populations are going to be different. An intervention in rural northern Wisconsin is going to be different than an intervention in Racine, for example. And so these reports really give us an opportunity to look at those changes over time as well, which is a unique thing about our data, is that we can look longitudinally.
And I'll just add to this really quick, Renee. When I saw that first report in 2019, I said, this is going to be impactful. This is groundbreaking work that's happening in the state of Wisconsin that's not happening in a lot of places elsewhere. And not only at face value, these reports, what's in them and what's the state look like, but the model that it presents, that we're measuring, identifying health disparities, and now tracking their closure. So now think about whether you can take that model and localize it to your location and do that same kind of work locally, where you're measuring and you're tracking.
Our statewide disparities project is called Healthy Metric. Healthymetric.org is where we house a number of other reports we've released over the past couple of years, 2 or 3 years. It's funded by AHW and WPP, a co-grant between those two groups. And then the project partners are WCHQ, so lots of health systems that you all might work at. Medical College of Wisconsin, researchers at UW-Madison, some data also from WEO is weaved into those reports, and then Marshfield Clinic Research Institute researchers as well. So it's really a collaborative group of individuals working to understand those disparities and provide you all opportunities to understand that data to improve them.
Yeah, really fantastic group of partners that it's good to be part of. So we welcome people into that.
Absolutely. So here's just a look at the Healthy Metric website. Encourage you to check it out at some point. There are a number of reports, most recently a maternal health report showing that women of childbearing age 18 to 45 utilize primary care only 63 or 65% of the time. So that's sort of a stark realization across the state. We also broke that down by county, so you can see primary care utilization by that age of women by county as well.
And I actually pulled out 2 reports to show here that have, they're very relatable to pharmacy, 2 recent reports. Evaluating change in health disparities in Wisconsin, blood sugar, blood pressure, and colorectal cancer screening. That's a recent report in 2024. There's also one in there, disparities in initial opioid prescribing from 2022. So a lot of relevance back to what we do in pharmacy is available on that website.
And that 2024 report compares data from 2019 through the pandemic around those quality measures too. So it's quite interesting. So here's just a map of the health systems represented in our improvement team. So we come together monthly to talk about a number of topics around improving disparities, look at data together, challenge each other, share interventions that folks are using. So as you can see, we have about 73% of the zip codes in Wisconsin covered, 14 health systems. Again, if you're a WCHQ member, and maybe even if not, we invite you to our group and to work together on this improvement.
And we're working hard to expand that to pull in community health centers,
Yeah.
for instance, FQHCs and FQHC lookalikes. So a lot of work's being done to get a better picture of what the population looks like.
And we know in community pharmacy too, that you all are doing a lot of really important, innovative things. So we'd also love to hear about that. So what do we do in our improvement team? We track interventions, we report out on our progress, we talk about the data. Our data analyst really digs deeply into our data set, compares, by male, female, insurance, kind of a couple of levels of disparity related indicators lately. And we ask each other questions and we wonder about the data. And someone over here says, oh, this is what we found. Oh, I'm going to go look at that back when I get some time this week, or bring in some colleagues this way. So really great opportunity to work together. We want to make sure that our measures are actionable. And we want to look at things over time, right? We want to make sure that the interventions are tracked and can be repeated. Our data is just 6 months old in most cases. So it's very recent. And we look at things that like I said, cross the care continuum. This is a tool we put together in the group, intervention tracking grid, where we look at opportunities for quality improvements. That's the vertical group or vertical list there. And then look at opportunities for evidence-based interventions related to disparity reduction. And as you can see, there are probably a lot of opportunities for pharmacy to be involved in patient education and, supporting folks with maybe medication delivery, not exactly on the list, but something that could fit into one of those buckets as well. Looking at community buy-in, what kind of things can you all do and offer in your community spaces?
This was a grid put together by one of the research partners. And while it's a useful tool to guide us with what's been known to work, that evidence-based best practices, on the flip side, it helps researchers start to quantify when they collect data from us. This is really ripe for research now, trying to figure out what interventions work to reduce health disparities. So they're using these grids that we fill out on occasion and send back to the research team to say what interventions or combination of interventions is working.
So this is one example. We have two slides here just of examples of what health systems have worked on. So this health system looked at blood pressure control specifically for Black patients who had Medicaid, actually. That detail isn't on here. But from 21 to 22, their intervention was really about the community work. So they identified this group, knew they had Medicaid, knew they had complex social needs. And then after their appointments or blood pressure checks, they were had a warm handoff to the community group. So community health workers, social workers, care management. And those care management staff, they ensured they had a follow-up appointment to check their blood pressure. They ensured everything was clear. They had their, a med pickup. They knew how to get the meds. And then that they had a cab ride back to the clinic, right? So, our Medicaid transportation in the state of Wisconsin is a great resource. And if you mess it up once, you don't get it back again, right? So a lot of these folks had unfortunately messed it up once. So they had cab vouchers to ensure that they could get back to their next appointment, and then also worked with the Medicaid transport company to schedule the appointment, and worked with the cab company with the cab voucher to schedule the appointment in that time. So the person left with everything they needed, other than an appointment reminder the day before, to make sure that they can make it back for their next blood pressure check.
And these are great examples of the work being done, but the model, think about the model we're looking at, where we're measuring something and we're doing something, and then we're measuring, did that then work? The other takeaway from this in the next example is take a look at the denominator sizes we work with. The reference population, the larger population, about 4,600 people. To move that number 1%, you have to move 46 patients. The smaller number, 279, to move that number 1%, you have to move 2.8 patients. So putting that into perspective as you take on this work, sometimes the goals we set sound very ambitious, but when you break it down to numbers, it's not. That once you understand the math behind it, that we can focus these efforts on smaller populations and actually get a really great improvement and move the overall number as well.
This health system was really focused on the Hmong population. So call out here, you see it says Asian Pacific Islander patients, not specifically Hmong patients, right? So in some of our service area, that is this patient population. So just thinking about the disparities indicators we have available to us, and are they the right tools, right? But this health system really focused on breast cancer screening with the Hmong population in their community. They tapped into their staff who were Hmong. They made sure that they were getting things right culturally, that they were using the right words. So for instance, they talked about breast health and not breast cancer. And they changed the materials that they were providing to folks to not only change the language, but change the content culturally to make sure that it was helpful then to those patients. And then they included their families in this intervention. So they created a community opportunity to do mammography in the community, invited everyone's family, and made it fun. They had some fun things for kids to do. They had some food, and it was a whole community event. And they did this a couple of times throughout this period and plan to continue it as they move forward. So big success and really a trust building opportunity for the health system.
Renee, I'll just add there, I think that coming from community health, I'm always really excited when we can match disparities work internally with community health outcomes and bringing community along for that ride. And while the payoff, when you can bring community into the discussion and actually make some meaningful change, it's pretty powerful.
Yeah, thank you. And that is so important, bringing community in. And that kind of good segue into talking about your why. When you take this work and on grounding yourself on why are you doing it? Some organizations, it's baked into their mission or vision. There's regulatory accountability, of course, but we don't necessarily want to do it for that reason. Try to do the right thing and make sure we get the accountability aspect. You want to be good social stewards. Is it a corporate directive? You know, some organizations, you get the directive from above. We're going to take this on. Being in rural health is very different. We had to create the directive. I didn't get a directive from above. We had to create it. We had to bring the CEO on board and get him comfortable with this, because this topic can be a minefield, and they don't want to step into a minefield. They want to trust that we're taking this on in the right way. So we spent about a year bringing my CEO on board at Ford Healthcare, and then he retired. Then I had to bring the next CEO on board. So you have to have grit and perseverance when you take this on. It takes time sometimes. We got him on board. He's our biggest cheerleader now. We took it up to the board. We got the board on board. So we had to take our message up first and get everyone on board and then bring it down. One of the whys I ground in a lot of times, and I have it up here, is the WHO definition of health. And this is from, I think, 1945, 1948. It's back in the 1900s, back in the 1940s, 70, 80 years ago now. And I think we lose sight of that over time. But that definition, the one right on top, in fact, about health is a state of complete physical, mental, and social well-being, and not merely the absence of disease. That's been baked into this for a long, long time, and we're only just kind of paying attention to it, it seems like now, but it's been part of what we do for a long time. So that's part of our grounding at Ford Healthcare, wrapping our heads around why we're going to take this on. I'm sure SSM, you're grounded in this in your mission and vision, right?
Yeah, absolutely. It is baked into the work we do, for sure.
And then the accountability elements going forward. There's a lot of accountability elements. A lot of what I talk about pertain to hospitals, but it's really the environment we're in right now. So it pertains to a lot of other places. The CMS commitment to health equity, for instance, starts looking at making equity a strategic priority. And there's a lot of pieces that go along with this: data collection, data analysis, quality improvement, leadership engagement. So we had to build that process out, all of those things, which are good processes to have if you really want to move the needle on this. There's also Joint Commission. If you're a hospital, you probably know what Joint Commission is. Joint Commission, this didn't surprise us when this came out. This came out, I think, a year or so ago. It started out as a leadership rule, and then it became a national patient safety goal. So they elevated it from the LD chapter to the NPSG chapter. It reads the same way though. And we got surveyed by Joint Commission before this was in full effect, and they said, we know it's not in effect, but we want to ask you about this. And we're able to blow their doors off with it, which was great. But having this, knowing what you're held accountable to is really important. Hospital designates an individual to lead activities to improve healthcare equity for the hospital's patients. I'm fortunate that gets to be me at Ford Healthcare. And it's a great position to have to guide and steer a lot of this work. And then lastly, the last thing I'd like to tie in on accountability is civil rights compliance. And sometimes this gets overlooked or not looked at it at all. In our organization, we're fairly small. Our C-suite is 5 people, CEO, CFO, CNO, myself, and a clinic operations director. So we get involved with a lot of other things. I get pulled into all kinds of things. And one of the things I get pulled into is signing off on civil rights compliance for the organization. And when you read through this, you're like, that sounds a lot like health equity. And so we started blending this into what we do on the equity strategy side of things. And there's 2 key points that come out of this, really 3. One is once it's named in civil rights that you're a protected group, that's going to be things we measure in equity. The other is there's 2 things that are called out specifically in here: LEP, limited English proficiency, so language, and the other is disability. And these are 2 areas that the Office of Civil Rights has taken enforcement action on with healthcare providers now. We've looked at examples at our organization where there was an organization in Florida that had enforcement action taken because the instructions they gave the caregiver weren't able to be understood because the caregiver is hard of hearing. Office of Civil Rights is putting IT companies on notice with this. If you create solutions that are only for English-speaking patients that can see and hear, it isn't an equitable solution. So things like virtual visit software platforms, electronic care, things like that, they're really looking at hard with IT companies, like, are you creating things that can be used by everyone for language and disability and all those things? So I'd like to anchor ourselves in what some of those accountability aspects are.
This is, as Chris mentioned, a long-term process, right? So definitely not a sprint, maybe not even a marathon. Maybe think about couch to 5K, then do the couch to 5K, then do the 5K, then think about the marathon, right? Like, but don't quit, I think is the summary for encouragement for me, is don't quit, and we're here to help you. So one thing we really wanted to talk about in Wisconsin is rural urban geography. So in 2018, 2019, WCHQ looked at the data set and pulled out by rural urban disparities. And we know anecdotally, there are certainly many disparities in rural Wisconsin. And we looked at that data and thought, there's not much of a difference here. I wonder why that is. And then our research partners helped us look at rural and urban geography, but in 3 different buckets: rural underserved, rural, and rural advantaged, and then urban underserved, urban, and urban advantaged. And when we pulled those data out, we could really see the disparities, especially in the rural underserved part of our state. And so we looked at those definitions by zip code, and we identified, distance to primary care. And we looked at Medicaid coverage. We looked at poverty rates, uninsurance, educational attainment, unemployment, and then the status of physical health and mental health. So with a very complicated algorithm, assigned each zip code within the state that designation of not only rural urban, but the underserved, sort of regular, I guess I've been calling it, and advantaged buckets. And then so you can see on the next slide, the obviously red is not good, yellow is okay, green is good. But you can sort of see how that trajectory happens, where the rural underserved is, really doesn't have a lot of resources, and the folks in those counties are sicker and, are in poverty more. And so, ding, ding, social determinants of health here. And so thinking about that in your work, when someone from a rural county drove 45 minutes on their last tank of gas till next week to pick up their medications, only to find out that they aren't refillable until tomorrow, or that one's refillable today and another's refillable tomorrow. And thinking about how to support those folks when they aren't going to make it back tomorrow because they don't have the resources, or they're not going to maybe make it back for then, another 90 days after that. And then this is just a map of the state. So you can see most of the state is rural. And we have a lot of unique challenges in rural Wisconsin for jobs, for workforce, for distance to primary care, distance for colonoscopy, et cetera. So just thinking about that as you continue with your work, and thinking about that in the context of our disparities.
And one of my passions has become the rural side of things. That's where my organization is. That's where I'm worried about my little neck of the woods in Jefferson County. And really looking at things through a rural lens and an equity lens, inequities look very different in rural areas. We are in inequity to start with when compared to the reference population. But also we have inequities within our populations, and very different ones if you go even to different rural areas in the state. So we try to look at this very uniquely, that we're going to look at our area, what's important to us, and we're going to address those issues in very uniquely rural ways as well. All right. With the background set, now we'll talk about what this Health Disparities Improvement Toolkit is. We had a subgroup together at WCHQ. Renee and Megan were part of this group. And we took all our knowledge, all the things we had to spend hours and hours and hours and hours researching. We put it in a toolkit. So let's see it.
So we've spent a lot of time this morning really getting us to this point, right? So you can finally see what we're talking about here. One of the main reasons when Renee first asked me to be a part of this work that I was so excited about it is that we often are doing a lot of Google searches, right? When we're looking for what's the best screening tool, and where's the evidence for this? And so you are scanning a huge space of all of the potential resources that are out there to help you get started in this work, or help you advance the work if you already have a really good foundation. And what I like about pulling all of this together is that you get to go to one spot and not have to search everywhere under the sun to find this information. So that was really part of the intent of building this toolkit, is to really help folks get some good foundation under them. Know that you can go to this toolkit and find evidence-based things, you can find evidence-informed things, and you can feel confident in the resources that are there to help guide you. You don't have to delete some of the noise that you can find when you go on a Google search, for example. So Renee has heard me say, I think it's like our virtual Rolodex. I'm not that old, y'all, to be using a Rolodex, but I know what they are. And so that's how I see this tool, as a one-stop shop for many of our folks to tap into, get what you need, and move along and actually start building your strategy work. The other thing that I'll mention there is that you can steal shamelessly from here. This is meant to be collaborative and bringing in all of the information from across our wonderful state. It is not meant to be a secret. So please take all of the things that you can possibly use from here and spread it widely. That's our hope. So we have some screenshots in the next following slides to help folks kind of understand what the toolkit is. If you have a personal device, then you would like to follow along with me, you are welcome to do that. Once you go to the Wisconsin Collaborative for Healthcare Quality's website, this is somewhat of the main page that you would find. You'll see if you go over across that big bar on top, you'll get to toolkits. As you drop down there, the Health Disparities Improvement Toolkit is what we're going to talk about today. Now, I want to mention there are other ones listed there that I also think you should check out should you have the time. So the objective of this toolkit, again, this is just in case you need to convince your CEO that this is good work. This is maybe a place to start, or other folks from your team. So the objective is really to share resources across our state. Take some of the great work that some of our hospitals are doing across Wisconsin and elevate that work, but also provide you with resources to help build this if you're just getting started. And it's intended for a lot of people. Again, from the community side, I think that this is great for hospitals. I think it's also great for a lot of our community partners and nonprofits that we work with. So I think it's a great tool for multidisciplinaries across the boards. So once you get to the toolkit, you're going to see these big buckets to help guide you a little bit more into understanding where maybe you want to focus your attention when you get to the toolkit. So we have a bucket for understanding health disparities. So some of those definitions we've talked about, we're going to go into each of these. So don't panic. You're going to be able to see it all. Health disparities in Wisconsin, a little bit of the specific data points that we've talked about. Resources around the social determinants. Many of us are now screening for social determinants on the acute care side, and maybe even on that outpatient ambulatory side if you're a part of a hospital system. So there's a lot of resources there to help you get started on that, or help to optimize that work. And then community and health systems collaboration to really showcase some of the partnership in community and how we've been able to move the needle on some disparity work by working with other health systems, and other community partners, like Renee mentioned earlier with the one case study. So if you were to click on the understanding health disparities, you'd get to this part. So there is many links within this toolkit, right? So I mentioned that it's meant to be a one-stop shop, so you don't have to go to all of these sites. And so when you click on these links, it'll take you to the resource you were likely looking for if you were doing a Google search. There's also the graphic that I'm sure many of us have seen now between equality and equity, and really to help paint the picture of how there is a difference there. And so there's also utilizing health disparity data for quality improvement work. So the CMS quality measure information is listed there. The CMS Health Disparities Guide is listed there, and frameworks around CMS and how to do this work. So again, it is meant to be a one-stop shop to finding all of those pieces in your definitions, again, to get grounded in your why, and then how to actually use this information to build some strategy.
And sometimes we Google around and we think, what is this organization that comes up first that paid Google some money to show up first on their list? So these links are sort of links that we use, links that we've vetted, links that are resources that have been helpful to us, articles that have been helpful to us. So just wanted to add that plug.
Yeah, good call. So now you've gone back out to the main page of the toolkit, and now you've clicked on health disparities in Wisconsin, and that's brought you here. So Renee was speaking to the difference between the rural and urban zip codes across Wisconsin and the deep disparities between the two. And so that is part of this. If you were to click on this, you'd be able to see this geography. Again, if you're from a rural space in your world, this is really eye-opening and helpful. As a part of a health system that covers a lot of urban and rural spaces across several states, I will say this is really helpful to help me paint the picture for leadership that may not be in Wisconsin. So if you're in that same space, sometimes our more rural spaces get a little bit more attention, I have felt, and I'm always fighting for the little guys in the rural spaces, but this is a helpful visual for those folks. Again, you've stepped back out to the main page and now you're in the social determinants bucket, okay? There is this wheel here to help folks kind of clearly visualize social determinant work. Many of the categories that we have focused on include, of course, access to care, but neighborhood and the built environment, economic stability, housing things, social connections, right? Education, all of those things that we really know make up 80% of someone's health outcomes are really right in their neighborhood, those social determinants. And so again, this is a place for you to come look at some screening options. Again, if you are new to embedding screening options into your space or are kind of loosely familiar, this might help really understand what's available for screening tools across the healthcare spectrum. And then the healthcare accountability resources. Chris mentioned a little bit of this earlier as well. So some of these resources are really helpful, again, in grounding you in that why, but then moving some things. So again, there's the new CMS rule around payments for acute care hospitals when it comes to SEOH screeners and so on.
And just a call out on that last page, if folks are interested in asthma, know about the Asthma Safe Homes project. There's a Milwaukee Journal Sentinel article there that really talks about importance of home asthma triggers in your home and what really is happening in people's homes. So it's very eye-opening and would encourage you to check it out if you're doing any asthma work.
Nice, thanks. Okay, you've stepped back out. I know this is a journey we're going on this morning. And now you clicked onto community and health system collaborations. So there's lots of links here, which just fills my cup, Renee, because that's the work that I'm so proud of doing. But in here, you'll see lots of examples of the work between community and health system collaboration. So it is broken down a little bit to help you kind of guide you further. So there's a whole piece about community health workers and doulas, those kind of care professionals that help support the work and really take the patients by hand after they've left a hospital setting or their appointment and making sure that they get back for care or they are taking their medications, for example. I heard a story from a community health worker in Western Wisconsin that, we typically ask folks, are you safely storing your meds, right? Are you taking your meds? Are you safely storing them? And yeah, of course I am. Yeah. And then they did a home visit and they were in a shoebox in the closet, all dumped out together, right? So in their mind, they were safely storing their medications because they were safely stored up in a closet, right? Not necessarily what you are all thinking is safe medication storage. So those community health workers play a vital role in really asking the right questions to our patients, not making any assumptions about what that actually means to the patient, which is beautiful work in helping address disparities.
And the pharmacy intervention here is how can we think about blister packs, right? And how can we work with that community health worker to get the blister packs, to get them weekly, to deliver them to the patient, et cetera.
Mm-hmm. Look at you solutionizing already.
Social worker.
So there's two other sections that I have not commented on yet. One is interventions to reduce healthcare disparities. So again, going into that intervention space, what are we going to do about it? We know about it. We've heard about it. We can't just talk about it. We got to do something about it, right? We never just screen to screen or collect a bunch of information just to be like, well, we know that now, but rather what are we actually going to do about that work? And then the additional resources and partnerships is a bit of a catch-all, right? So what else might be helpful to our teams in building this work?
One call out I want to make on the additional resources page is that patient mini documentary series. So we worked with a partner at MCW over the past couple of years to do 3 patient documentary series on behavioral health and maternal health and immunizations. And so we worked with folks typically with Medicaid insurance or who were underinsured, unfunded, community health workers, and really talked about the experience that the patient had in a space that wasn't in the healthcare setting, but was in their home. So getting that story and hearing sort of their side of how the healthcare story went. And we know that, in our worlds, we all have a story and an experience, and the person we're working with has a story and an experience, and the truth is likely somewhere in the middle, right? So the documentaries aren't meant to be accusatory or cause any angst or frustration, but they're really meant to have an understanding of what that patient experience is.
So if you've gone into the button for interventions to reduce health disparities, you'll see that grid tool that Renee was speaking to earlier that was developed in regards to just keeping you on track for this. I love me a tool to help keep me on focus, but this is really helpful to lay it out all out there. We often do really great work, but we don't do always the greatest job of documenting it to be able to prove that it is in fact effective and we should replicate it across our state, for example. So this is a great way to do that. And then there are some case studies utilizing Disparities Improvement Toolkit, specifically this grid tool, that are listed there as well. And we'll highlight those on the next slide as well.
Yeah, I would love to see some pharmacy case studies there in the future. what a great opportunity to intervene and tell our story. Oh, did I go one too far? No.
Yeah, here we go. So these are just quick one-page spotlights. So if you are doing great disparities work, I think we would like to hear about that, to be able to spotlight it as well. So there are two that we wanted to reference today. Again, one is out of Bellin Health, one is out of Gunderson. Really easy to read, quick spotlights. So on the left-hand side, you're going to see the measure that they were looking to address in the disparity itself, the targeted population, and then what is the intervention goal? What were they looking to accomplish here? They have a little bit of data, a little bit of the background, what the intervention was, and that's it. Something that perhaps when you see this, you could say, I think we could do that. I think we could try that on for size and see if it works for us. And that's the intent of this, is to elevate those doing really great work, but also encourage folks to replicate this in your area if it makes sense for you to do that. In regards to places to start, so we have the healthy metric. Again, Renee talked about that earlier on how the data is pulled in and how it can be utilized. The rural and urban health is divided here as well in how we define zip codes, for example, urban place and health equity critical issues and practice, for example. So again, mostly resources here to help folks get started. Renee, anything else on this? No? Okay.
I'll put in a plug on the rural, though. That top rural article, the Robert Wood Johnson Foundation, Advancing Health Equity in Rural America, is really a great article. It's worth a read. There's an executive version that's even shorter, or the full version. It's really a great read, though, if you're working in that space in rural Wisconsin.
Great. And then lastly, that we want to highlight from the toolkit itself today. Again, I encourage you all to check this out for yourself and play around. There are equity toolkits listed here. So the American Hospital Association's Health Equity Roadmap, I've tapped into that a lot in my work in community health. UW-Madison has health innovation program toolkits. There's not a lack of other toolkits running around, right? But what a part of it is going to be helpful to you all in moving the work that you're trying to do. There's also some training resources there. The documentary series that you had mentioned earlier is listed there. And then a little bit about insurance coverage, should that be helpful.
So this is a place to start, some resources for you. I appreciate the upstream image. You know, we talk about upstream. What does that mean? What do you see in your mind? I see oftentimes, let's pull someone out of the river, but let's not let them fall in the first place, right? That's the goal. So how do we do that? And how do we think about that? And so this image, I think, is helpful. You know, oftentimes we talk about siloed care. You know, what image comes to your mind? Well, in dairy farming, we've been putting silage in bags for a really long time, not silos. Actually, we don't use them much anymore. They're dangerous. You have to climb up top. Sometimes your feed goes bad. So they're not good. So we use bags. We can see how much feed we have and we can easily keep it fresh. So I encourage you to think about those visualizations as you think about siloed care. And let's put our care in bags and see each other and work together and easily get to our corn silage and our haylage and mix it up, right? So appreciate a little dairy humor, but really, you know, as you're using these terms and thinking about these concepts, put some more meaning behind them, I guess, is our push and call to action. And let's pull people out of the river and not let them fall in the first place.
Yeah, depending on where you are in your organization, you might have the opportunity to work more upstream, whether it's with housing or economic development areas we get involved with. And that's very upstream. But there's other areas as well that we can focus on.
So our collaborators were the three of us and another colleague that works at the Health Innovation Program. She actually has made a transition and is going to nursing school. So that's exciting to be a MPH and transition to actually want to provide care. But can't thank these guys enough for their contributions to this really meaningful toolkit. And also just a call out, if there's anything anyone wants to add or think would be useful to other people, this is a living thing that we put on a website for a reason and don't PDF and store away. So we want to add to it and we want to update it as often as we can.
And I can't thank you enough for, both of you enough for being part of this, letting me talk you both into it. So now bringing this home back to pharmacy. So we have the toolkit. We got a really unique thing going in Wisconsin with the Wisconsin Collaborative for Healthcare Quality. We have the Healthy Metric. We have health disparities reports, all this data, tracking, trending. We got toolkits. We got people working on it. Where's pharmacy fit? So I've thought of 3 just really quick examples. There's plenty of others. There's a ton of opportunity out there right now. If you look in this space, a lot of times these challenges are just waiting for somebody to step up and say, we can help with that. Vaccinations. So what I think about with vaccinations is beyond just access. Are we measuring, are we using data to measure what arms is it going in? What arms isn't it going in? How do we get the vaccine to the right places so it's so equitable care and reduce health disparities? We saw a lot of this data with the COVID pandemic that was all stratified all kinds of different ways. What are we doing with that then? Are we using that to actually get better? Chronic conditions, same thing. Stratify your outcomes. Use data to identify where your disparities exist. They may be very different in Milwaukee than they are in rural Jefferson County. Target your interventions to those disparities, measure impact, that quality improvement cycle, a plan, do, study, act, and then tell your story. Get out there and be that case example that's in here. Have a pharmacy case example. Here's what we did. Here's the challenge we took on, and here's the impact we made with that. It's so important to tell your story on this work. And then smoking cessation is one that this disproportionately affects different populations. It's an equity story all in itself. So great opportunity to kind of reinvigorate how we take on smoking cessation through an equity lens. Other opportunities I think about is every year when we have the resident poster sessions, I walk around looking for equity-based posters. Lots of opportunity there. I don't see a lot of work yet, but I'd like to see more. Great opportunity to start doing projects that look at things through an equity lens and actually show improvement. And that'll have power in your organizations as well. Look at the impact we have had on these populations. So with that, we're leaving time for questions at the end. So that's why we zipped through this a little fast. Am I good? Okay. So, okay, excellent. So we're leaving time for questions, but we'll do the assessment questions real quick, and then we will open it up for questions. So learning assessment question 1. WCHQ's mission is to, and there's 4 choices there. Improve the health and well-being of the community, bring meaning to performance measurement data by creating information that drives improvement in healthcare quality and affordability, improve health outcomes for low-income residents, all of the above. Answer is B. Answer A is for healthcare's mission, but answer is B for WCHQ, bringing meaning to performance measurements. Okay, question 2. What percentage point difference in health measures between populations represents a substantial disparity? C, 10 or greater for substantial. All right, number 3. True or false? And I'm sorry, I don't think we covered this, so that's all right. We might have.
Well, WCHQ is a member organization. So if you're a member, of course, you can come to our trainings and education opportunities. And there are some that if you're not a member, you can come to as well.
Yeah.
So
general,
it's kind of tricky, but generally it's true.
Yeah, general. And we put that out there because there's a lot of education events that are out there, and we link this at the end that are open registration. And I think many of your organizations, if you work for a health system, you're part of WCHQ. Yeah. You're a member.
Yeah.
So
we quick plug. We have a colonoscopy, colorectal cancer screening 101 demystified webinar coming up with Dr. Jennifer Weiss, who's a gastroenterologist at UW-Madison. And there are no questions off the table about colonoscopy prep at that webinar. So if you you know, if you don't know and patients have a lot of questions for you, please come. And if you want the recording, sign up and I'll send it to you.
Yeah, we've had some great past meetings. I remember one a few years ago on diabetes. We had a pharmacist from Gunderson that presented at that one. It was a really great presentation. So great opportunity for pharmacy. Last question. What entities have accountability elements related to health equity? And I was trying to remember to put this in earlier on. I forgot to do it. So I'll mention here that insurance payers also have accountability. Increasingly, as we sign new payer contracts at a health system level, there's questions in there. Do you have equity initiatives? Is equity a strategic priority for your organization? Do you have training programs for your physician staff on addressing health inequities, health disparities? So the answer here is all of the above. So insurance payers is another accountability aspect. All right, with that, we left a little time for questions at the end. Did pretty good on time, so thank you both for coming. Anything we can answer for anyone? Thank you. Maybe step up to a mic, please.
Okay. First, I'd like to thank you for mentioning community health centers right off the bat. Community health center pharmacy, I think, is a minority of the pharmacists here, and we have our own unique challenges. So thank you for that. Second, goes back to the limited English proficiency slide where you talk about civil rights.
Yep.
And I guess what advice do you have for us for prescription labels? Many software vendors offer English and Spanish, and that is it. And we serve a much more diverse population than just English and Spanish speaking patients. So do you have any advice on how we can give our software vendors, and ours is a pretty big one that should have more than just English and Spanish?
Well, one, I think push back on the vendors. I mean, that's easier said than done, but push back on the vendors. But what else could we maybe create in addition to that? So handouts in the pharmacy that we can do in multiple languages, or maybe even on the academic side, is there research projects going on in that space right now with health literacy? So this would tie into health literacy, of course, that if you're providing prescription instructions in a way they can't understand, that's no good. We got to figure out how to get around that. I will say the one thing all of this has done at Ford Healthcare is it started those conversations. So bringing this stuff to the forefront, we're now having conversations about things we never had conversations about before. And that's sort of the first step with this is we start talking about, oh, we got to really look at this. And we push this out to our staff as well. We've done a lot of presentations for the staff at Ford Healthcare. They're now bringing stuff to me saying, hey, did you know that our wayfinding in the hospital is only in English? I'd never paid attention to it. So those are things now staff are bringing to us. And that's what we want is we want everybody thinking about all these things through an equity lens now. And what is it that we can work on to improve? It won't happen overnight, but
I'd just add one challenge too, to think about cultural concepts and not just language, right? So I mentioned the Hmong example, changing from breast cancer to breast health. You know, so if someone needs to take a medicine 3 times a day with food and they're fasting until the sun goes down, you know, how does that work? So that extra moment of time to talk with someone about their daily schedule. This medication is supposed to be taken with food. Are you eating 3 meals a day, 3 times a day? Are you, you know, how and when do you eat? And is that a possibility? And what flexibility can you provide? And what sort of importance and priority can you also provide, right? If someone is fasting till evening, how can you problem solve with them about something to eat with that medication that will, you know, I'm thinking about an antibiotic or something, right? So just sort of that call out as well.
any others?
Good morning. Thank you for your presentation. Kate Harkoff with PSW. I have a few questions just to kind of continue to inform the conversation. You mentioned sharing of stories, and I love sharing of stories. How would someone go about submitting that, getting that information in front of WCHQ? Is that clear as part of the toolkit, or what process would they follow for that?
You can email me directly. And
Okay.
that's a good question. I wonder if that is on the bottom of the page. So I'll check that and make sure that it's there.
Wonderful. And then does the formatting get taken care of by the WCHQ team? Can there be a conversation of sharing that story verbally, and what sort of format would be helpful?
Yeah, so what we've been doing in the context of the story sharing is looking for, local news articles and putting that kind of on the list, or media releases that folks are putting on their website. If you do have videos and YouTube things out there that you've done, we certainly would want to add those as well.
And then final question, as far as the invitation for other community partners to join and get connected, can you talk a little bit about that pathway as we think about our healthcare extending into so many facets within all of our counties across Wisconsin?
Yeah, I think you hit the nail on the head. All of our counties across Wisconsin that do something very differently in each county, right? So I think that I don't have a blanketed answer to do this thing, or how can you be invited? I think if you're interested in this work, if you're doing something, if you want to learn from other folks, you're invited, and you should send me an email and we can connect about how to contribute to that group. And I can bring you up to speed more than our presentation today on sort of what we've been working on and how you can connect. So please send me an email if you're interested. rsutk@wchq.org. Sounds great.
Great. Thank you so much.
No, thank you.
Renee, I'll add to that real quick too. So I became involved, like a year plus ago. Renee makes it real easy, y'all, to get involved in this. It is like, I need a lot of help to be involved in things, but Renee makes that very, very simple for me to be engaged and want to continue to be a part and learning from others. So don't be shy. Renee is great.
I don't make you do a lot of work, but I do make you talk to me.
Fair.
Hi, Michelle Chewy. I direct the Collaborative Center for Health Equity at UW. I just wanted to share that, if we're going to reduce health disparities and improve equity, we have to measure it first. And we have to measure it in an evidence-based, reliable, and valid way. So this presentation really spoke to my heart, and really appreciate all of the work that's been done to get us to this point. I was reflecting a little more about your slides about intervention development, and wondering about what you all are doing to sort of bridge the clinicians and the individuals on the ground who are recognizing all of these problems with potentially individuals at our 3 pharmacy schools who could help evaluate and develop interventions for you. Can you talk a little bit about that? Thank you.
You want to start with that, Chris?
Well, I'll take it, I guess. So I'm glad you noticed that, Michelle. So we were, I was specifically thinking about you when when I was talking about that intervention grid, because I think this is really ripe for research right now, is getting the measurement side down and really trying to zero in on what are those interventions or combination of interventions that are creating results. There's not a lot of research out there yet, so it makes it really ripe for researchers. As far as your second part of your question, I think this is the first step in all this, is bringing this to the pharmacy profession here, introducing everyone to it. This is kind of where you start. And I think from here, we start having those conversations. How does pharmacy students or residents or pharmacists in organizations start having impact and fitting in with this? This is an open invitation from us just to bring this and give everyone that insight, and here's where you can start right now. So.